So why don't we move on to our next group of speakers? And we thought it'd be nice to revisit this debate style format for our next discussion. So we're honored to have Dr. Uma Mahadevan and Dr. Fernando Velayos. I don't have time to read through all their credentials because they'll have no time to speak. But briefly, Uma is a professor of medicine at UCSF, co-director of the UCSF Colitis and Crohn's Disease Center, and special interest in pregnancy and fertility. She's the PI of the PIANO program, which is a pregnancy and inflammatory bowel disease and neonatal outcomes. And Fernando is my chief of GI at Kaiser San Francisco. We're very pleased to have him as the lead of our department. And he's also the director of the regional program for inflammatory bowel disease for all of our patients in Kaiser Northern California, as well as serving on the editorial board or the editor for several prestigious journals, including Digestive Disease and Sciences, Gastro, and CGH. So we asked them to do a debate style format on kind of a potpourri of IBD topics. And as always, please submit your questions in the chat bar, and we'll have about 5 to 10 minutes at the end of the presentation to ask them some questions. So Fernando and Uma, thanks again for joining us today, and I'll let you take it away.
Great. So we're kind of on the same computer, so Uma is right next to me. And we thought, to be honest, we thought we would spare you on a Sunday morning hearing an entire 50 minutes of a married couple debating on a Sunday morning. So what we decided to do instead is we're going to do some quick presentations, and then we will have cases at the end, which will highlight some of the items that we talked about, and then we'll be able to get into a little bit more of a discussion at that time. So let's see if this works. All right, so we're going to talk about, I'm going to give a brief update in terms of what's new in IBD, including some presentations from the UEGW meeting, which just finished last week, so the European GI meeting. Uma will talk about updates in pregnancy, and then we'll finish it up with some case discussions and then questions. All right, so the first topic, and these will be kind of a smattering of topics in terms of what's new. The first thing is what is new in terms of treat to target. Take this backwards, but so as you can see here, what we have is there's different types of targets, and you can see how they've evolved over time. And one is not necessarily better than the other, but kind of moving from left to right, you can see that you can start with clinical remission using standardized scores, which you can translate it into clinical practice in terms of symptoms. Steroid-free remission, which is really a better target. So in other words, you're doing well, plus you're off of corticosteroids. We have biologic remissions or markers of inflammation. And then you're moving, you can go into endoscopic remission, and then obviously histologic remission going all the way to normalization. So what's new in terms of this discussion is this new endpoint used in the Stellara Unify study, which is this concept of a histologic or a histoendoscopic mucosal healing. And at some points, it might be intuitive that you want to have both an endoscopic healing as well as a histologic remission. And it's one thing to say that this is important, another one is to say that we have the formulas for getting there. But you can see that in looking at this study and also a paper that was published earlier this year, if you look at the data from that study, when you have endoscopic plus histologic remission, you have an overall clinical remission rate of about 61%. Which is interesting because that means that other things may be kind of leading to symptoms, compared to 38% if you just use endoscopic improvement and 34% for histologic improvement. So if we try to put this together in terms of how to bring treat to target into practice, you can see that you're going to have some assessment of active disease, including mucosal ulceration. There's a process of risk stratification for which you'll decide on your treatment. And the key thing here is that usually you want to do some type of follow-up assessment. It doesn't always necessarily mean a colonoscopy, but usually sometime in anywhere from 3 to 6 months, depending on the severity. I mean, clearly symptoms you may assess much more regularly. And if you haven't met these targets, these predefined targets, you're going to change, and if you do, you're going to continue treatment. So where we are in 2020 in terms of updates is that although it seems simple to say no symptoms, no positive markers, no mucosal ulceration, the fact is that sometimes there's a discordance, sometimes they're not all the same. And so this is the area where we're increasingly trying to kind of be more finesse, because sometimes patients will have no symptoms. There's really not a lot of inflammation, but their CRP or calprotectin is elevated. That might be a case where, particularly if you've already gone through 2 medications and they seem to be doing over quite well, changing to another biologic may not necessarily be the case. On the other hand, if you have that and the patient's on mesalamine on the lower dose and all it requires is adding additional medication or even adding an immunomodulator, that's very different. So what we're trying to do is really, we kind of identified the target. I think everyone is good about starting a treatment, following it up, making the decision. The challenge is when there's a discrepancy in these. And so that's kind of an ongoing process. But in general, for me, I tend to use the fact if there's no mucosal ulceration is really one of the key targets. All right, next is updates on AGA guidelines in terms of what to do for patients who have IBD. What medication, how do you choose for induction of remission for both biologic naive and TNF experienced patients? So again, this is published within the past year, and this is a little bit different from the other guidelines in that normally there was kind of this sequential movement from one medication to the other, and really rarely was one medication really brought up as preferred over another. And at some point it makes sense because there truly are no head-to-head comparisons. But what they did in this guidelines is that using network meta-analyses, tried to essentially use the data to try to come up with some ranking of these therapies. And it's not perfect, but if you look kind of on the left, for patients who are biologic naive, if you're going to start a TNF inhibitor, the preference was for infliximab over adalimumab for ulcerative colitis based on the relative efficacy. Similarly, for vedolizumab, prefer over adalimumab based on efficacy, and I'll go a little bit over the study that led to that. Ustekinumab, when this came out, was effective but not ranked in the guidelines because it had not yet received FDA approval. And tofacitinib or Xeljanz, the oral JAK kinase inhibitor, also effective, but based on changes in the FDA label, it's not approved as a first-line therapy for patients who are TNF naive. On the other hand, for patients who have previously received infliximab, the guidelines seem to prefer both ustekinumab and tofacitinib. Now, this doesn't mean that the other therapies are not effective, but just wanted to highlight, and this is something you can read, it's actually a very nicely done set of guidelines. So this was a study that compared vedolizumab versus adalimumab or Entyvio versus Humira in ulcerative colitis. And what you can see here, this was a randomized controlled trial. And if you look at the week 52 endpoints, you can see that vedolizumab was superior to adalimumab for clinical remission and endoscopic improvement, but not corticosteroid-free remission. Interestingly, if you look at, even though the overall endpoint was favorable for vedolizumab as well as anti-TNF naive, interestingly, there was not much of a difference in the TNF exposed. So that led to the recommendations from the AGA, at least based on this network meta-analysis. Now, one thought here was, well, perhaps there's always been a concept that for adalimumab that it might be relatively underdosed, and that if we use kind of higher induction or even therapeutic drug monitoring, that might actually improve the efficacy. So again, in terms of what's new or updates, there was that study that looked at compared high dose adalimumab. So in other words, patients received 160 milligrams for 4 weeks, and then 40 milligrams every 2 weeks, compared to standard dose, which is 160 milligrams, then 80 milligrams and 40 milligrams every other week. And what you can see here is that there was really not much of a difference between the high dose group and the standard dose. They essentially had pretty good equivalency, meaning that when the studies were decided that this dosing probably is the right dosing, and that higher dosing for induction doesn't necessarily get you a significant improvement. So continuing with updates and guidelines. So how about combination therapy? When should you use combination therapy? Again, this is somewhere where the AGA has nicely highlighted that When you're using a TNF inhibitor, particularly if you want to maximize your efficacy or eliminate immunogenicity, that you should combine with thiopurines or methotrexate rather than using biologic monotherapy. And I would say probably more relevant for infliximab. Now, this was conditional recommendation with low quality evidence. Now, the fact is that we've actually recommended for a long time to use combination therapy with vedolizumab and ustekinumab. And primarily that's been because, particularly when it's used as a second or third line agent, particularly if patients have either developed antibodies to prior drugs, we kind of want to save it. And so we've often recommended combination therapy. That being said, if a patient has simply lost response to either to a TNF, but not necessarily due to antibodies, the evidence overall suggests that both vedolizumab and ustekinumab tend to have rather low anti-drug antibodies, about 4% for vedolizumab and about less than 3% in the ustekinumab Crohn's disease registry. So the thought is really that for using these, it's probably not as essential as with the anti-TNFs for combination therapy. That being said, if a patient has failed therapies, particularly because, or biologics because of drug antibodies, I will usually add methotrexate to these therapies. And there's a little bit of information to kind of highlight why the basis of those recommendations. This is an older study, the UC Success study, that randomized patients naive to TNF inhibitors, either to azathioprine, TNF inhibitor, or a combination. And what you can see there is that the steroid-free remission group, that the combination group did a lot better, and that there does seem to be a stepwise effect for mucosal healing with the combination group. Looking at the slide on the right, you can see that for both Humira, so the kind of the top two bars are Humira and infliximab combination therapy, and the lower two are infliximab and Humira, infliximab and adalimumab monotherapy. You can see that whether you use infliximab or adalimumab, those tend to be roughly the same, but there's a big discrepancy in the two when you combine them. Where the top graph is using it as combination therapy, you can see that your outcomes are a lot better, either drug, compared to if you use them either as monotherapy. So looking at updates again in terms of guidelines and new studies that have come out this year, we're kind of re-looking at the use of mesalamine in IBD. So there's clearly no question that mesalamines are FDA approved for mild to moderate ulcerative colitis, but they tend to be used in other situations, either out of need or out of situations that kind of make sense, where they may or may not be the most effective and could actually represent low value care. So for mild to moderate ulcerative colitis, where there is an indication, the discussions in the past used to be whether to use kind of a standard dose, which is 2 to 3 grams a day, so about 2.4 grams a day versus a high dose. And the data really suggests that, particularly in the mildest patients, that you can use that standard dose, about 2 to 3 grams a day. So essentially, if you compare using the high dose versus the low dose, you're about using about half as much and also half as much cost to essentially get the same outcome. For those patients that you may have already on the higher dose who have mild disease, who have been on remission, it's not unreasonable to put them on 2 to 3 grams a day. The data show that that should be equally effective. And really reserving that high dose mesalamine for moderate disease or suboptimal response to standard dosing, or if patients have been on steroids before. Now, Crohn's disease is somewhere where there's not a lot of information. We typically extrapolate it from sulfasalazine, but often we will use it, particularly if the patient does not otherwise have a strong indication for starting a biologic or an immunomodulator. But where the guidelines and the data this year have kind of emphasized is for the mildest of patients who you do an endoscopy and they have ileitis, or even something that looks like probably Crohn's. If they're otherwise asymptomatic, the thought is that giving them mesalamine does not really provide any efficacy. At that point, the ACG even recommends for these very mild patients that you can actually do nothing or give budesonide or decide if they may need and start an immunomodulator. A couple of studies this year have also shown that patients who are on a biologic or an immunomodulator plus mesalamine, that those patients can be deprescribed, given that the mesalamine is unlikely to be providing any significant benefit for the patients. And there's no evidence that mesalamine in these situations provides a better chemopreventive effect if inflammation is otherwise controlled. All right, so finishing off here, in terms of proactive therapeutic drug monitoring, this just came out at UEGW, where the first half of the study was kind of a high dose, low dose adalimumab study, but then they re-randomized the patients. And the second part was the therapeutic drug monitoring, where you either do a proactive therapeutic drug monitoring for patients who are on Humira, or you do a clinical adjustment regimen. And for those who are proponents of proactive therapeutic drug monitoring, this study was actually quite eye-opening, in that no matter if you did just clinical adjustment, you essentially did a treat to target, and you evaluated symptoms and adjusted Humira or changed the medications in that sense, or if you use therapeutic drug monitoring to guide your what dosing you're going to use, there was really no significant difference in the two groups. Another study presented at UEGW with a different design similarly showed that this concept of proactive drug monitoring was no different than clinical adjustment. So this is something kind of looking forward, that if we're looking at therapeutic drug monitoring, there seems to be data now that, at least early data, that a proactive approach may not necessarily have the impact that we think. So another update from UEGW is for patients who are on 10 milligrams, as you know, the label recommends that after 8 to 16 weeks that patients on 10 milligrams twice a day reduce to 5 milligrams due to the potential risk of blood clots with the 10 milligram dosing. And so this study actually randomized patients who were otherwise doing quite well and randomized them into on 10 milligrams twice a day to either continuing that dose or de-escalating to 5 milligrams. And the bottom line is that what you see is that about 23% of patients who went down ended up flaring, compared to about 10% who stayed on the 10 milligram dose. And we can maybe discuss this in the cases, but I think here it's clear that patients will basically flare when you go to the lower dose. And so if we're using it particularly as a second or third line agent, I think it's a discussion to have with patients. Realizing that you are reducing, and that sometimes you can recapture, but other times you cannot. All right, so what I'm going to do, so we can move to the to Uma's talk, and then to get to enough time for the cases. What I'm going to do is just finalize the discussion here on IBD and COVID-19. And patients often are very concerned about their therapy, whether to continue their medications. They're afraid that they may be at risk for worse outcomes. So what I decided to do is really just kind of present the guidelines based on some data, not the best, but emerging data. And here you can see that for patients who are not infected, so in other words, the patients who do not have COVID, if they don't have IBD patients, we should really try to maintain their current therapy. And if they flare, do the usual adjustments, but really try to minimize steroids. It's clear that steroids seem to be the risk factor for worse outcomes, not actually biologics or immunomodulators. If you have a patient who's on therapy, who actually does develop COVID, taper corticosteroids where possible. You can switch to budesonide. You can continue 5-ASA, budesonide, and rectal therapies, but typically you're going to want to hold oral therapies and delay biologics at least 2 weeks until the symptoms resolve. And then you can resume therapies after symptom resolution or retesting is negative. So with that, I'm going to hand it off to Uma. I'm going to stop the video for a second while we switch, and she will talk about managing the pregnant patient.
Okay, hello everybody. We're going to keep this part short. I really just want to give you the slides as a basis for our case discussion and debate. And then Suraj, I'm going to ask if you can be moderator if there are any questions for the audience that comes up during the debate, because I can't necessarily see the chat. So feel free to interject anything that people write in. Okay. So the preconception and pregnant patient, there are a lot of slides in here, which are mostly for your reference. I'm going to go through some of this. So why do we care about pregnancy and IBD? Half of the 1 million people in the United States with inflammatory bowel disease are women. Most of them will have IBD during their fertile years. And if you have IBD, you have a higher risk of adverse outcomes. So to be in remission, you have a better chance of having a healthy pregnancy. But what is the safety of these medications? So remember that we don't use the category A, B, C, and D anymore. So those are moot. If you're talking about drug safety, you go by the new pregnancy and lactation labeling rule, the PLLR. What this is the FDA changed the label. So now they give you information and you make the decision yourself based on that. You can no longer say, I'm not going to use this drug because it's category D. That was never how the FDA meant for this data to be used. Instead, you read the data and you come to your own conclusion. So to help with that, for the first time ever, the American Gastroenterology Association and the Society for Maternal Fetal Medicine came out with a joint statement. The patient-facing part is the IBDparenthoodproject.org, and the physician or provider-facing part was the clinical care pathway for pregnancy and IBD, which was published jointly in Gastroenterology and the American Journal of Obstetrics and Gynecology. So OBs and GIs should be on the same page. This tool goes through preconception, the 9-month pregnancy plan, delivery, and the postpartum. So preconception, you want your patient to be in remission for at least 3 months prior to considering conception. And I personally do a scope if they haven't had one recently, or really confirm that they're in a true remission. Fertility is the same as others their age, unless they've had surgery in the pelvis, which can decrease fertility. And if appropriate, you want to involve other people, including nutrition, if they particularly a patient who has low weight or has a small bowel surgery, a maternal fetal medicine specialist for all of my IBD patients when they're pregnant, but for people with prior complications, you want that ahead of time, and a colorectal surgeon if the person has a J pouch or an ostomy. You want to make sure their healthcare maintenance is up to date, and you want to manage their medications, including stopping methotrexate at least 3 months prior to conception. If they're on sulfasalazine, increasing their folic acid to 2 milligrams a day, making sure they're off steroids, continuing azathioprine and biologics, and in general, avoiding tofacitinib if you can. So preconception care does lead to less disease relapse and more adherence with IBD therapy and folate use, as shown in the study from the Netherlands. One thing when you talk about pregnancy, it's also important to talk about contraception. Women with IBD have higher rates of VTE, in part because of the IBD, but this can be even compounded if they smoke and if they use oral contraceptives with estrogen. As you may have heard, tofacitinib can increase the risk of VTE. So if you have a woman with IBD, generally it's recommended they use LARC, long-acting reversible contraceptives. So these are progesterone-based, IUDs, progesterone implants, injections, etc. So this is a recommendation actually for all women, because LARC is more effective. That's why you use contraception to avoid pregnancy. LARC is more effective for preventing pregnancy, but it also doesn't contain estrogen, so there's a lower risk of VTE. So this is important for all women, but particularly women with IBD. Fertility, as I mentioned, is similar to other women their age, unless they've had surgery in the pelvis. But the question is, most of that data was old. With the new laparoscopic techniques, is fertility rates after J pouches better? In very small studies, the suggestion is that it is in fact better. Fertility treatment, though, our assisted reproductive technology is not as effective in patients with IBD as it is in patients without IBD. So that's something to remember. And to sort of combat that, what we offer some of our patients is if they need a J pouch and they're ready to get pregnant, we'll do a subtotal colectomy with endoleostomy and leave the rectal stump in place until they're done with their childbearing and go back and create the J pouch, just to help preserve fertility a little bit. Cannabis, this being Northern California, this comes up quite a bit. The American College of OB/GYN does not recommend or induce the use of cannabis because observational data has shown it's associated with low birth weight and preterm delivery. It can be associated with negative neural development of the child, and it can be detected in breast milk, which can influence brain development. So a lot of IBD patients use cannabis. They should not do it during pregnancy and lactation. A couple of other really interesting things, low-dose aspirin. Low-dose aspirin has been associated with a reduction in preeclampsia. Preeclampsia is increased in patients with IBD. So you will see many OBs want to know if they can put your pregnant IBD patient on aspirin. And the answer is yes, they can, because aspirin, low-dose aspirin taken with food, very low risk of triggering their IBD, and can definitely improve outcomes. So this is something that your OB may ask, and the answer should be yes. So now that they're pregnant, if they're in remission, I usually see them in the second trimester. We map out when their last dose should be. They're seeing the MFM regularly, continuing their medications. But what if they're flaring? So if they're flaring, remember that their lab tests can be different because of pregnancy. So sed rate CRP can be up, ALP phos can be up, including in lactation. That's all part of pregnancy. They can have low hemoglobin and low albumin, so you have to keep that in mind. You can do an unsedated, unprepped flex sig without monitoring, and it has not been shown to be harmful in any trimester. If you need imaging, an MRI without gadolinium is preferred, but if it's an emergency and you need a CT, you need a CT. And surgery should be done for the same indications as you would if they're not pregnant. And we have done surgeries in patients with severe UC. All the medications are the same during pregnancy as not during pregnancy. The difference is I would never do a new start of thiopurine in pregnancy, just in case they get one of the adverse reactions. Of course, not methotrexate, and we try to avoid tofacitinib, particularly in the first trimester. This is just data from one of our junior faculty at UCSF showing the safety of flexing in pregnancy in women with IBD. There was no increase in adverse outcomes. It was done in every trimester, and in over 70% of cases, it actually changed or it affected management. And if you have a patient with acute severe ulcerative colitis, this patient should be in the hospital, get IV steroids. Don't delay on therapy. That's the key thing. People say, oh, she's pregnant, we don't want to give her anything. The sicker they get, the higher the risk to the pregnancy. You need to be more aggressive in this setting, not less aggressive. Involve the surgeon early, give them infliximab, et cetera, as you would someone else with severe UC. Fortunately, as Fernando went through, COVID-19 is not increased in IBD, but pregnant women, sorry, let me go back here. Pregnant women are at increased risk for COVID and adverse COVID outcomes. So while I tell my IBD patients your medication and your disease does not increase your risk of getting COVID or having a bad outcome unless you're on prednisone or have active disease, being pregnant does increase risk. So they should be even more cautious. Okay, and this is just looking at steroids, which can increase preterm birth, low birth weight, and gestational diabetes. You really don't want to use steroids as your mainstay of treatment in pregnancy. In the past, people would stop their biologic and just use steroids. That's actually more harmful than continuing the biologics. Thiopurines have not shown a increase in adverse outcomes when either mother or father takes it. And then just briefly, the Piano Registry, if you have any pregnant women with IBD, please send them to us at piano@ucsf.edu. And we're up to 1,700 patients now. And this is an older data cut. The new data cut is under review, but the results are the same. So if you're on azathioprine, group A, there's no increase in any adverse outcomes, including birth defects. Same with if you're on biologics, group B. But if you're on combination, there is an increase in preterm birth and an increase in C-section. And that increase in C-section is driven by active disease and is primarily in ulcerative colitis patients. So again, another reason to really control disease tightly. When we think about biologics in pregnancy, we should remember that biologics are antibodies. and they're IgG1 antibodies. And beginning at least around week 13 or 14, biologics cross the placenta. And by the third trimester, you have an exponential increase, a very efficient increase in that transfer. So 80% of antibody transfer occurs in the third trimester. That's how mother transfers drug to the baby. And because monoclonal antibodies are IgG1, except for Tysabri, and except for certolizumab, which is a fragment, you see very efficient transfer. So the baby is born with high levels of drug. What does that mean? We looked at the different biologics, and as I mentioned, certolizumab is a fragment. It doesn't have the FC component, so there's no active transfer. But for infliximab, it has the highest rate of transfer, and babies are born with 2.4 times the amount of drug as the mother. Adalimumab and ustekinumab are 1.4. And natalizumab, as I said, was IgG4, so it's less avidly transferred, but so the levels in the baby are low. Interestingly, vedolizumab, though it's IgG1, also had low transfer. But what does this transfer mean? We found that there was no significant association between infection risk in the baby and drug levels at birth. And our safety data on TNF in pregnancy has been replicated in multiple other registries, including the TREAT registry from North America, the Evasion French study, the TEDdy study, and of course, Piano. So the data is increasing on the safety of these medications. In Europe, many people still recommend stopping biologics in the second trimester. The Europeans have a very glasses half full approach to pretty much everything, including safety. So in America, we say, okay, well, everything so far looks safe, continue the drug so they don't flare. And their take is more, oh, well, even though it's safe so far, we don't know enough yet, so let's stop it to avoid transfer. And what happens now that's coming out with this, which we've shown in Piano as well, is when you stop, the mom flares. And when the mom flares, the child has a worse outcome. So this study that was published in American Journal of Gastro from the French cohort looked at what happens when you stop drug. When you stop drug, mom flares. So when the mom has a relapse in the third trimester, that is the only situation in this bottom row here where there's an increase in childhood infection. So mom flares in the third trimester, worse outcomes for the baby. Also with adalimumab, if you withdraw adalimumab, mom flares, worse outcomes for the baby. So healthy mother, healthy baby, continue the biologic through pregnancy. The newer drugs, ustekinumab, emerging data suggests low risk. Again, remember with the biologics, there's very little transfer in the first trimester, if at all, and that's when organogenesis occurs. And so you're really not going to see a lot of birth defects with monoclonal antibodies in theory, because they're not getting exposed in the first trimester. Vedolizumab, same thing, very low evidence of adverse outcomes. Tofacitinib is different. It's not a biologic, it's a small molecule. So it will cross in the first trimester, and animal models have shown an increase in birth defects. There are so few human examples of tofacitinib in pregnancy that we can't really make a statement. So far, it doesn't seem to be any adverse events, but if you look here, it's 11 maternal exposures in clinical trials. So you really can't make any statement on that. But I do try to avoid tofacitinib in pregnancy, not in all women. You shouldn't deny women care based on reproductive potential, but only in pregnancy. So I avoid it in the first trimester of pregnancy. If they really need it, second and third trimester, we have used it. Then method of delivery should be at the discretion of the obstetrician unless they have active fistulas or rectovaginal fistula. That is the only time we as gastroenterologists would say they need a C-section. Another thing your OBs are doing are inducing patients at 39 weeks gestation. And when they do this, you have a significantly lower frequency of cesarean section. So this is another thing you're going to see your OBs doing. Okay, so I'm going to quickly go through this. Breastfeeding while on azathioprine is okay, almost nothing goes across breast milk. In piano, we looked at the biologics. The amount of transfer in breast milk is at the nanogram level, and there was no adverse events, so they can breastfeed. One thing to remember, fenugreek is an herb that's in most lactation teas. It's also associated with bloody diarrhea. So we tell our pregnant patients, don't take fenugreek as a lactation stimulant. Okay, and baby's response to vaccines is similar to, I'm sorry, the slide is all jumbled. Baby's response to vaccine is similar whether they were exposed to biologic or not, so that's good. But we recommend no live vaccines in the first 6 months if they were on a biologic except for certolizumab. But what happens if they do get the only live vaccine we give in the first 6 months, rotavirus? And the answer is pretty much nothing happened. These kids were fine. And then developmental milestones out to 4 years show no adverse events, like no decline in expected development. If anything, these kids did better, but most piano babies are at IBD centers and are higher socioeconomic status, so that could play a role. And then finally, daycare. This was controversial because in Europe, they said that if the baby was exposed to biologic in utero, they shouldn't go to daycare for a year, which is great if you get 1 month of maternity, 1 year of maternity leave like in Europe. But if you get 6 weeks, like in the United States, that's really not feasible. So we looked in piano. If a child goes to daycare, there's an increased risk of infection as opposed to not going to daycare. But the medication the mother was on during pregnancy did not impact that risk. So these babies can go to daycare. That is primarily a quick rundown of what's new in IBD and pregnancy. So preconception planning and education is key. Immunomodulators and biologics allow refractory patients to achieve remission and conceive. And that children have excellent developmental milestones. Remember, no live vaccines for 6 months, which is essentially rotavirus in the US, but all other vaccines can and should be given on schedule. And if you do have someone you want to refer to us, we'd be happy to see them. It's all done remotely. They don't need to see us, but it's piano@ucsf.edu. And with that, I'd like to invite Dr. Velayos back so we can have some debate. And Radhika, are you and Suraj going to monitor the chats or pipe in with any audience questions?
Yeah, we'll let you run through your vignettes, and if any questions pop up, we'll interrupt you guys.
Perfect. Is Fernando on? I don't see him.
I'm over here.
Oh, hey. Okay, good. So I got the room with the good lighting. Okay, so we are going to talk about, the first case is a case with moderate to severe ulcerative colitis. So we have a 42-year-old man with newly diagnosed pan-ulcerative colitis, having 6 to 8 bowel movements a day with blood, and colonoscopy shows Mayo 2 disease, so moderate to severe disease throughout the colon. They failed mesalamine, 4.8 grams. What would be your next step? Would you do prednisone 40 milligrams daily and then just put him back on mesalamine? Would you do azathioprine? Would you do infliximab, adalimumab, vedolizumab, ustekinumab, tofacitinib, plus or minus immunomodulator? Fernando, what do you think you would do here?
Right. So just briefly, so Mayo 2 disease. So at that point, you're having mucosal breaks. So meaning you do have erosions or ulcerations, friability. And so typically that often is an indicator to respond to that treatment, particularly somebody who's having a clear flare. Prednisone and mesalamine may sometimes be an option in the patient who's really had mild disease and maybe flares out of the blue, but in this case, without any other history, I'm reading it as really saying that we should escalate therapy. From the guidelines we talked about, azathioprine is not really an induction agent. So really here we have, what is your top agent for ulcerative colitis? And here, what I would say, we know that tofacitinib is not really an option. We talked about, adalimumab actually being an effective treatment, but if you wanted to pick the most effective treatment, you would probably pick one of the others. So I would say, I think probably would be most common would be infliximab with an immunomodulator or vedolizumab without an immunomodulator in this case. I think both of those would be appropriate answers. I mean, ustekinumab would be as well, but depending on what's covered, I'd say the infliximab or vedolizumab.
Great.
Uma, what do you think? You're going to tell us what happened, but what do you think?
Yeah, so I think if you were to go by the new AGA guidelines, they do not recommend azathioprine in this setting. If somebody requires prednisone, if you remember from the old Bill Fabian data at Mayo Clinic, which was just redone this year and showed the same thing, that half of these people are not going to be able to be maintained on mesalamine, and this patient's sicker. So I would generally agree and move on to a biologic. I would not use azathioprine. And by the guidelines, it would be infliximab or vedolizumab, and the guidelines were written before ustekinumab before it came out, and so they didn't put it in there, but ustekinumab is an option. And it often comes down to insurance. What I would not use is adalimumab in this setting because of the Varsity trial that looked at adalimumab versus vedolizumab and showed that vedolizumab was superior. Yeah, so any of those would be okay. With tofacitinib does work in this situation because of the VTE. The FDA changed the guideline that you can only use tofa in someone who failed a TNF. It has nothing to do with its efficacy, because I actually have several patients I put on tofa first line and they're very happy and doing great. It was more a mandate. But yeah, so I would do that. And so now the one thing is, let's talk about azathioprine, because we see a lot of times patients coming in on azathioprine and it is cheap, but not that effective. So say the patient says, look, I'm not ready I've just been diagnosed. Can I just try to go back on mesalamine? How would you manage that in this patient you want to put on prednisone and then go back on mesalamine? How long would you give him? What are the guidelines you would offer in his care?
So, I guess I would say that, being in two places, one is at university and the other one kind of seeing patients both as referrals, but at the same time kind of seeing, I think, to be honest, I think a broader spectrum, including some of the milder patients. This is where I think, though, that understanding kind of their history and how much you need to act, I think, is important. So again, azathioprine is not an induction agent. It never was. But in theory, this is somebody that you could induce with prednisone and put on azathioprine. It really just depends on how sick they are. I mean, right now there's really not enough context, but that would be an option if somebody's a little bit on the milder side. They need to be on something. Even though I think clearly, escalating to a biologic would resolve the problem. And 6 to 8 bowel movements is starting to get more on the moderate and significant side. So I think that, and again, there are patients who if you told me that this patient's had 20 years of mild disease really on mesalamine and then had a flare, I think that's very different than if somebody who's recently diagnosed. We know that patients who have a shorter onset, this would probably show that this patient is progressing more aggressively. So there, I think I would probably move to a biologic quicker.
Yeah, I would agree. I think we have a bias because we see the sickest patients, and perhaps there are people out there that could do okay on that prednisone to mesalamine, but I don't see them. But I would definitely have a very quick hook if that was the only thing he agreed to. And if he at 8 weeks is unable to taper off steroids, then he's on to something else. I generally don't use azathioprine very much and would move on. One point would be.
I will say, I think that's where the treat to target, though, I think is nice, because what it is that it's treatment agnostic. So it's really saying that you are dealing with your reality and the patient in front of you and all of these things. But the premise of good medicine is that once you start a treatment, you're going to make some assessment at some defined period of time. And if you have not really achieved the response that you're expecting, you're then going to renegotiate and move on to a different treatment.
And guys, we have 2 questions here, kind of based on delivery. One question is, are you using subcutaneous vedolizumab? And number 2 is for patients who prefer injection to infusion. Does golimumab have a role here?
So subcutaneous vedolizumab is not yet on the market. So we would happily use it if it were out, but it is not out. It was held up at the FDA for PK issues. But at least in the study, sub-Q versus IV looked identical. And so I would use them interchangeably. So if sub-Q vedolizumab came out, I'd be happy to use it. The second question, yeah, golimumab. I think golimumab and adalimumab both are FDA approved for ulcerative colitis. The deltas were small and similar for both. I can't say that I use a lot of that. If a patient wanted an injectable, I'd go with ustekinumab, which actually had very good data in ulcerative colitis. The first dose is IV, and then it's injectable every 8 weeks. I think infliximab remains everybody's go-to for the sickest patients. It remains the most effective we have, if at least in an inpatient setting where we have the best data. But adalimumab and golimumab really haven't shown that level of efficacy, at least in studies. And so in a biologic naive patient, I would prefer to go to vedolizumab or ustekinumab because of safety. And with vedolizumab and ustekinumab, you don't need an immunomodulator. There's no additional benefit to the immunomodulator. So that's also nice for your patient as opposed to the anti-TNFs. Remember, tofacitinib, you don't use an immunomodulator.
But that being said, it's not that adalimumab and golimumab have no efficacy, right? It's just a modest efficacy.
Correct.
So if somebody needed, so I guess it's also important to, you know, if you have a patient who's on it, or for example, the question that was brought up, somebody needs an injectable. I mean, you may decide to use ustekinumab if it's covered, but at the same time, it's not wrong to use one of these two. But more to say that, particularly if you have a sicker patient, that going down that sub-Q route may not be the best one. But for you have kind of a milder patient, or if somebody who really wants an injectable,
yes,
it's
you're
okay. I mean,
right.
It's just simply that you know the data that there is a more effective therapy for this in this head-to-head trial.
Correct. A more effective therapy and also a better safety profile. So, okay, so let's go to the next slide. Going backwards, sorry. Okay, so the patient achieved clinical remission on vedolizumab monotherapy, and the FLEX-SIG we used to treat to target FLEX-SIG at 12 weeks showed it was Mayo 0, so completely normal mucosa. But histology showed mild activity, so chronic active colitis, and calprotectin was mildly elevated at 190, and let's say 120 was normal in that lab. And the patient is completely asymptomatic. So the patient's off, not on steroids, has complete endoscopic response with Mayo 0, but has histologic disease activity, elevated calprotectin, no symptoms. So what would you do? Would you do nothing? Would you check a vedolizumab level and optimize? Would you add an immunomodulator? Would you switch to another therapy?
So this is what I was talking about for in the treat to target, that, you know, you really, it's almost like the tight control of diabetes. You want to make sure that, you know, you're 95% of the way there. And so the question is, what is the cost, or how much do we want to push to get this perfect? I would say that calprotectin being mildly elevated and the histology showing the mild activity, this patient still has a significantly good outcome compared to where they were 12 weeks before. So what I would say here is, I think the opportunity is to check a vedolizumab level and see if perhaps it's there's some room to go there. I think doing nothing, I would probably check the level. I don't necessarily, without understanding the level, that I would necessarily add an immunomodulator. And I definitely would not switch to another therapy, given that, at least at this point, given that the patient seems to have done quite well.
Yeah.
What do you think? How perfect did we get it?
I would agree. I think I brought this up because many times we get consults sent to us because with this exact scenario, with the question, people get into this whole treat to target and you go to the meetings and everybody talks about histologic healing, but we really can't achieve histologic healing in the majority of patients. So I think you have to be careful. I've seen people being switched from an effective therapy to something else purely based on histologic healing or a calprotectin, even though endoscopically they look normal and they were asymptomatic. So I think first of all, it's shared decision-making with the patient. You have to kind of lay it out to them as to what the goals are. They need to agree to participate in whatever additional thing you want to do. I would check a vedolizumab level and optimize. A vedolizumab level at trough should be greater than 14 micrograms per ml. And so if this was low, I might go to every 7 weeks or every 6 weeks, depending. But aside from that, I would get an immunomodulator. I certainly wouldn't switch therapy. And remember, it's only 12 weeks. So histologic healing can occur over time. And so maybe at 1 year, it's going to look better. So I would be cautious in this setting, and I would just check a level, like you said, and optimize. Okay. Any questions, Suraj? Or?
Yeah, 2 questions. One was, I think you just addressed it. Do you shorten the time between vedolizumab infusions? I think you mentioned that you would maybe go to Q7 or Q6
Yeah,
weeks.
you can't change the dose. The dose is set at 300 milligrams. So the only thing you can do is shorten the interval.
And then another question, not necessarily related to this, so I can either let you finish the vignette or...
Oh, go ahead.
Okay, so question is 5 centimeter distal rectal cuff of proctitis causing iron deficiency anemia. No response to Canasa plus 4.8 grams of mesalamine PO. No response to hydrocort enema or suppository. Does not want biologic. So I guess refractory distal proctitis to ASAs and enemas and doesn't want biologic.
And how severe was it?
Severe enough to cause iron deficiency anemia from daily bleeding, but I don't see an actual severity written here.
So, the obvious answer there would be budesonide foam. So it doesn't look like they tried budesonide foam, and budesonide was superior to mesalamine rectally in trials. And so I would do budesonide foam there for 8 weeks to see if that makes a difference. If the budesonide foam does not make a difference, this is a situation where if they don't want a biologic, where I would use like 8 weeks of tofacitinib to see if you could heal the mucosa, and then you could stop the tofacitinib. And if they ever need it again, you can go back to it because you haven't immunized them.
Gotcha.
Amanda, would you do anything different?
No, I agree. I think you have to kind of go through the shared decision making, be aware of the FDA label, how it's written. But I think that it is ideal for a situation like that.
All right. And then one additional question was, could you quickly go through the drug levels you target for the biologics?
Sure. So I think what Fernando presented, and something that's constantly every year getting hammered at, is that prophylactic drug monitoring. Even though I personally do it, it makes me feel better, but it doesn't look like there's any real data to support it. Fernando presented the Serene Crohn's data with adalimumab, where prophylactic drug monitoring didn't seem to be a benefit. Taxit was another study that didn't show benefit there. So while I do it, I'm now realizing that it perhaps is not supported by data. So what is supported is reactive drug monitoring, where, as in this case, there is still some activity and you want to see if you need to change things. So for infliximab at trough, I shoot for between 5 and 10. For adalimumab, the guideline was 7.5, but if they're active, I shoot for greater than 10. Ustekinumab, the clinical trials suggested 1.2 micrograms per ml, but if they're active, data from different institutions suggested shooting for a level greater than 5. Golimumab and certolizumab, I don't check their levels that often, but it's whatever LabCorp says, or Prometheus, they have a rate. That's one I don't check that often. Tofacitinib, there are no levels. I think I covered the main ones, right? Fernando, do you use different levels, or?
You mentioned the vedolizumab level as well as greater than 14. No, I would say that here the distinction is, if you're checking it and someone is doing well, those are the levels. If someone is active, that's where we may push. So for example, for infliximab, sometimes greater than 10. The adalimumab, like Uma said, greater than 10. But you have to kind of caution if somebody has a reasonable level to not just escalate to just see what happens, because usually you're going to lose time there, and that's not going to show a lot of efficacy. And I would say that for the vedolizumab and the ustekinumab, that kind of pushing those levels seems to have less, there's kind of less guidance in terms of that. So I would say, like you said, particularly for ustekinumab, greater than 1.2 is really just detectable. But if they're active, kind of pushing for greater than 5.
Yep, great. Okay.
So Uma, I think we're almost done, even though I think we started a little bit later, but just doing the time check, maybe finish this vignette.
So Suraj, do you want us to go to 10:46 or do you want us to?
I polled the audience and everyone's very much enjoying this, so feel free to extend into break. This is really good. So
Okay.
however much time you guys need.
Sure. So just cut us off whenever you want. Turn off our mics. We're okay with it. So you chose to continue vedolizumab monotherapy. The level was 16 micrograms per ml. The patient works in a school and is concerned about coronavirus and wants to stop therapy. Fernando, what are you going to tell him? He wants a letter.
It's the letter.
We're writing so many letters.
There's a lot of letters. And then I mean, obviously it makes sense. I mean, because here you're on medications that affect the immune system. And so it's actually quite normal to be concerned about the outcomes. But there's been several, published studies now in different conditions. There's the Secure IBD registry. There's another one in rheumatology. There were also some other studies from New York, kind of early in the pandemic. Also one using the Optum database. We're also looking at some of this within Kaiser, where it really does seem to be that the use of corticosteroids before, before a COVID diagnosis is really the risk factor for severe COVID outcomes. And typically that means, hospitalization, ICU, and even mortality. There does not seem to be a huge signal for kind of generically for immunomodulators, oral immunomodulators, or biologic therapy. We can't give more information, for example, here with vedolizumab, just because the numbers are not there to kind of give good, precise estimates for the individual therapy. So that's probably with time. But as a concept, we would say this would be clearly you're going to use. This would be population-based guidelines, which is social distancing, use a mask, et cetera. On paper, his risk of developing adverse outcomes and acquiring COVID is the same as someone who's not on vedolizumab.
Correct. And that's what my letter says. Continue therapy and follow norms for your area. Okay, so let's move on to the next case. So though you told him he could continue, he chose to stop therapy. He now has a severe flare and was hospitalized. He was started on infliximab plus azathioprine and achieved endoscopic and clinical remission. Unfortunately, he lost his job and was without insurance for 6 months. During this time, he was on no therapy and now again presents with a flare. Fortunately, he was rehired by his school. What would you offer him? Would you restart the infliximab plus azathioprine every 8 weeks, no loading dose? Would you switch to ustekinumab, tofacitinib, or go back to vedolizumab?
So this question, I think, gets to the concept of what to do when somebody has, again, it's a misnomer, a drug holiday, or essentially interruption in biologic therapy. With the concept being that with these breaks and then re-induction, you can essentially potentiate antibodies, which can give you both an infusion reaction as well as just develop a neutralizing antibodies, which reduces the efficacy. And clearly here we want to get him well faster, and obviously try to avoid steroids because he was rehired by the school. So here what I would say is that kind of restarting infliximab and azathioprine every 8 weeks with no loading dose is a reasonable one. The question really, there's two aspects. One is, do you go back to a prior therapy or do you just move on? I would say that since we know that this really provided benefit for him, I think it's reasonable to think about using infliximab. The azathioprine to try to reduce immunogenicity, and then no loading dose is also reasonable. I will sometimes, depending on how sick they are, do kind of a modified dose. I'll either do like 0.48, but there's kind of a school of thought that reinducing in that 0.26 potentiates immunogenicity. And so we kind of alter the induction a little bit when they've had a drug holiday. Also, what I'll do is I'll check a antibody level about a week after their infliximab dose. Because clearly at that point, if they've developed antibodies, you probably will want to move on to a different therapy. I don't know what you do, or if you would think of it any differently.
I do exactly the same. There's absolutely no benefit in checking an infliximab level before you start therapy because you're not going to see anything. You need to prime them. I don't reload generally. If it's been a long time, I might do 048, but 6 months, I would just restart every 8 weeks. I would check the infliximab level a week after the first dose. And if they already have very, very low drug levels, then I might go to Q4. If they have antibodies, I would move on. He's a young guy. You don't want to go burn through all his therapy. So I would restart the infliximab azathioprine, though it's not wrong to go to ustekinumab or tofacitinib, I think, in this setting. Okay. Suraj? Yes,
sorry.
no?
There was one question as far as do you use IV hydrocortisone in these cases with induction?
I would consider using, generally you don't need to use it, but in this patient where you're restarting, if he's not on prednisone already, which he may have been, which you may consider in this situation, I would use 200 of hydrocortisone at least for the first few doses. But honestly, I have to say we've gotten away from that. And in practice, I'm not. I just restart with the infliximab because if they're going to have a reaction, chances are they're not going to continue on the drug, and you want to know.
Got it.
Yeah, and good.
And I was going to give you the go ahead for case 2. I think we're liking this.
Okay. Are you sure?
You sure?
Okay. All right.
All right. You said it.
A 25-year-old presents with a history of Crohn's ileocolitis for 8 years. She's been successfully managed on adalimumab monotherapy for the last 4 years. She's now developed perianal fistulas, and on query notes her symptoms worsen in the few days before injection. So you scope her and you see that she has mild to moderate inflammation of the ileum and moderate ulceration of the rectum. You check a serum drug level at trough, though technically with adalimumab, you can do it at any time, and it's 10 micrograms per ml. So Fernando, this patient now has breakthrough symptoms, has a drug level of 10. Would you go to 40 weekly and add an immunomodulator? Would you change therapy? And if so, to what?
So what I would say here is that at 10 there you are kind of getting to a level which should work. I mean there is a body of literature suggesting that perhaps infliximab can increase higher doses of infliximab improves healing for perianal fistulas. Of course, the main randomized trial for all these therapies for fistulizing disease, as opposed to post hoc analyses or kind of retrospective data, is really with infliximab, showing that it's efficacious. So knowing that this is very morbid, she's 25 years old and developed fistulas, it sounds like despite being on therapy, I would move on to infliximab with an immunomodulator.
So Fernando, I'm going to debate you on that one. While I agree that would be fine, there is some data to suggest in fistulizing disease that they need higher drug levels.
Correct.
And she is 25, and the anti-TNFs are really the only drug with very clear efficacy in fistulizing disease. Why not go to weekly with an immunomodulator and an antibiotic?
So the antibiotic, yes, it's clear that from the studies that when patients are on antibiotics, whatever the therapy, that their fistulas do tend to heal. It's often when you stop it. So I think as an adjunct for sure. And as I said, I don't think it's actually wrong to move up to the adalimumab 40 weekly and an immunomodulator. The issue here though is just simply that, it's, the loss of time. So I would say that it's not wrong. If she's doing, again, maybe I'm missing that she developed fistulas while on the therapy, but if she kind of already had, so I would say that the likelihood of this is going to be efficacious is going to be low. That being said, to your point that for perianal fistulizing disease, typically we shoot for higher levels than we would with only luminal disease.
Yeah, I don't think either is wrong. I think that I might try weekly with an immunomodulator for 4 weeks with an antibiotic, have her meet the surgeon, and if she's not better, move on. I wouldn't try it for a long time, but I may try it. So she was able to, I wrote these cases, so I let myself win. She was able to
Also kind of knew what was going to happen. You guys wanted a debate. We have to give you a debate.
to reach endoscopic and symptomatic remission on adalimumab 40 weekly and azathioprine 2.5 milligrams per kilogram per day. Her fistulas healed with the aid of exam under anesthesia, antibiotics, and the above therapy, and she now wants to conceive. So would
let me ask you,
Mhm.
what would you tell her? So we kind of know about azathioprine. You kind of talked about that. Safety of adalimumab, or just say, you know what, when she's pregnant, we have to switch everyone to certolizumab.
Yeah, no, so definitely not switch everyone to certolizumab. We see that sometimes, and the rheumatologists still do that. You want to, all these therapies now have shown, compatibility with pregnancy. So you don't want to switch her to, especially somebody with fistulizing disease. Fistulas are one of the hardest things to treat. And because she required the azathioprine really to get her where she is, I would continue both therapies through pregnancy and lactation. Now, if she, for example, was started on adalimumab and azathioprine 40 every other week, doing well, no fistulas, and that she's been in a stable remission, I would consider stopping the azathioprine in that scenario. In this scenario, somebody who had significant fistulas and broke through 40 every other week, I would definitely continue both therapies through pregnancy.
What about starting azathioprine, even with the same situation, but she says she wants to conceive? Would you start azathioprine kind of in this, either if she tells you that she's already pregnant and she's not on this medication, do you ever start azathioprine during pregnancy?
No, I really try not to start azathioprine during pregnancy in someone who's never been on it before, because even if their TPMT is normal, there's still a risk of bone marrow suppression. There's still a low risk of pancreatitis, all these other things. There's also some increased cholestasis of pregnancy with azathioprine. So I wouldn't start it for the first time in pregnancy. But if she's on it already in the situation, I would continue. The couple of times I have started azathioprine in pregnancy are in patients who were on it prior to pregnancy and stopped it for their pregnancy. And then I started it at that point.
Okay, one question from the audience. How late in pregnancy is too late to induce remission with a biologic in a UC or Crohn's patient?
How late is too late to induce remission? It depends on how sick they are. So for example, once a patient is 37 weeks gestation, she can just be delivered. So at that point, if there's any concern, you could just deliver the baby. So if somebody is, for example, after 35 weeks gestation having a flare, I may just put them on prednisone to get them under control, have them deliver, and then start the therapy. But if it's someone with severe UC in hospital, you also want to save her colon. So if it's more than if it's 37 weeks or more, that's where I would say just deliver the baby and deal with the mom. If it's less than 37 weeks, then I would treat her with whatever was most appropriate to get her into remission.
Got it. All right. So I think
that is it for our case.
Oh, awesome. Okay, great timing. Thank you guys so much again for this wonderful presentation and these vignettes. Everyone was very engaged.